Various discipline specialist physicians, while attending patients who consult them for a fee, often push such patients, mainly of female sex in menopause, to request the general practitioners to prescribe vitamin D-based treatments and clinical tests for the care of osteoporosis and for the prevention of bone fractures. Under such a pressure, the general practitioners were so compliant that vitamin D cholecalciferol became third ranking in the pharmaceutical expenses of the Italian national health system, while increasing by 25% yearly. Since the Italian State Audit Court has already issued sentences about the accountability of general practitioners in overprescribing, it is a duty to ask about such drug consumption. The prescription of non-activated vitamin D alone is recommended in two rare conditions, osteomalacia and rickets, in which the bones are flexible and soft, not fragile. They do not break, they flex. So why is vitamin D so prescribed a drug? In August 2018, Kaiser Health News appointed the endocrinologist of the University of Boston, Michael Holick, of having disclosed information about the effectiveness of vitamin D for osteoporosis without adequate scientific evidence, thus being indirectly the cause of the costs that can be read overlaid. The New York Times unveiled the high compensation that the pharmaceutical industry gave to Professor Holick for this misleading media operation. The most accurate studies with the highest number of cases suggest that 1. It is useless to request tests to dose the blood concentration of vitamin D in healthy individuals, as there is no thresholds that marks the biological effect of deficiency of this vitamin. 2. For possible dangerous depositions of calcium in the arteries and urinary tract, it may be harmful to prescribe long-term vitamin D, especially if activated, except in osteomalacia and rickets. 3. Bone measurement testing through computerized bone mineralometry is not recommended for osteoporosis screening. It is recommended only in over 65 women and in other patients with high bone fracture risk, previously calculated with 10 easy self-diagnostic tests on the network, such as the DEVRA. Though the cost-benefit analysis of osteoporosis screening is not proven to be beneficial in preventing bone fractures. It is a good general rule that the patient does not ask to his general practitioner to prescribe a medication recommended by a specialist, to whom the general practitioner has not formally requested advice. The denial by the general practitioner is supported by a sentence of the Supreme Court of Appeal. Patients ought not to encourage doctors to prescribe treatment against regulatory standards, professional ethics, and good practice health care. In this case, doctors have no professional obligations. Such a refusal to passive prescription still leaves the patient free to address any specialist for a fee. However, under these conditions, it would be more appropriate for the patient to undertake the costs of clinical tests and therapies, without charging the community and without compromising his general practitioners in choices that are up to him.